Dear diary, so today is, I'm just kidding. Okay, so this is sort of like me capturing the different moments that I've had in the labor ward. So let's start from the very first beginning, from the beginning. First day was crazy because obviously you are so confused, you don't know what is happening, you don't know what to expect. And I remember I was having a conversation with my family, like literally they were seeing me just be grossed out as I was watching this video of this woman giving birth. And I really thought I would not enjoy midwifery because like vaginas opening up, it's not a pretty scene, it's not. And then there's blood all over. Anyway, let me not gross you out. First day, it was quite eventful. The first day, obviously there's still a whole lot of admin that happens, students coming in, operational manager doesn't know what is happening. But anyway, the very first birth that we saw, this woman, she was in our admission room. So how our ward is set up is we've got an admission room which has got 2 beds, and then there's like a little exercise area, I guess you can call it, where you've got like those exercise balls so that patients can sit there. It helps with the dilation. And then obviously there's some benches for them to sit while they're waiting to be because they have to be examined to check how far dilated you are. And then you only come into the main labor ward if you're 5 centimeters and above. If before that, they will not bring you in. So anyway, so after you're 5 centimeters, then you come into the main labor ward, which has got 9 beds. And then after the labor ward, then you've got theater for obviously emergency C-sections and just normal scheduled C-sections. And like you can have tubal ligation and all of the other jazz. Anyway, so this woman, she was in the admission room. She wasn't dilating as quick as we wanted her to. So obviously the doctor prescribed morphine for her just to give her pain relief and that sort of thing. So that was in the morning when she got morphine. And then at around like 12, she is screaming her eyes out. Like she is screaming. She's like, she feels like when you want to push, you feel like you really need to go have, I'm trying to find the proper terminology to put this. You feel like you really need to poo, like badly, like badly. But the thing is, we don't allow them to push by themselves without us supervising them, because if you push uncontrolled, you can actually tear really badly, and that's just a whole nother complication that you don't want. So when we are supervising you and we're advising you on how to push, we can help prevent those tears and all that other jazz. So anyway, she's in the admission room, she is screaming, and we're just like, what is happening? So anyway, they brought her into the main ward. Now we want to examine her to see what is happening. She gets on the bed, within 2 minutes the baby was out. We were just like, what is happening? Because we are confused, we don't know how this whole thing works, and this baby was just out. And obviously there was a registered nurse there, and they knew what was happening. And then now they started telling us, go fetch this, go fetch this, go fetch oxytocin, now we need to measure the baby. And we don't know where anything is in the ward. It was crazy, it was madness. But anyway, after the first couple of births, you get used to the routine of, okay, after the baby's out, we need to clamp, we need to get a sample of the umbilical blood, it needs to be sent for test. So it needs to go into this container. It's like a blood test tube that has to go in and all of that. So there's a whole lot of thing that goes with it. But it was just crazy the very first birth we saw, which is like, we were not expecting it, because I would have loved for something that's, slow and calm, you're eased into it. But it was just so quick, like everything just happened so quick, we didn't even catch anything. But obviously as the day goes, there were a lot more births, everything was slower. We get to touch the baby, or we get to cut things. We are first time students, they don't allow us to do much. But obviously it's the first few days, it's more about observation. And as a midwifery student, there's a certain number of competencies that you need to do. So for us, we need to see 5 deliveries, and then we need to deliver 15 with supervision. And then we've got 5 conductions. So conductions is when you're guiding another student through the birth and telling them what to do and that sort of thing. So that was the very first day and the first birth. And then comes my first delivery. Guys, that delivery was just beautiful. That day in itself was just crazy. Like, it was in the month of September. I don't know what has been happening, but there's a lot of births in September. Like, mothers, what have you guys been doing in December? Because, oh my word, the mother babies just popping up is crazy. Like, September was crazy for us, and it was the exact same time I was placed for labor. So there were babies just coming and going. So that day was crazy. They were like, I think they were having 3 births happening at the same time. So, I just had to be hands-on everywhere, and I wasn't expecting to catch the baby that day because I only had 2 observations. Like, I'd only seen 2 being properly done, and then with some I would come like after they've already given birth, so I didn't see how the whole process works, and then I just help her to prepare the baby and all of that. So I'd only seen 2, and I really was not ready to catch this baby. But anyway, this sister was like, we're gonna catch today. I'm like, oh, okay, this is happening. All right, so anyway, we're helping the woman push properly, because when you, okay, I can't show you, but like when you push, you put your legs up like this, and then the woman has to hold her thighs here so that she can pull forward the legs, and then push her head forward. It just helps to bring the pushing power to your pelvis so that you can push the baby out. Anyways, I'm busy helping this woman out and all of that, and then the sister has to sort of like open up the vagina so that the baby doesn't stretch the vagina too much by itself without us helping the vagina itself. It's almost like when you've got, like, sticky, it's like when you've got elastic now, you don't want to just pull it all at once because it will break. You need to pull it slowly so that it relaxes and opens up by itself. So pretty much we help the woman with that. So anyway, the head was out. It was crowning. That's the word that we use. So the head was crowning, and the sister was like, okay, catch your baby. I'm like, what? And the babies are so slippery because they're covered in like the liquor or the fluid, the amniotic fluid that's inside, and then they're covered with poo, and then there's blood, and then sometimes the baby will pee and poo as they come out. So they're just all slimy, and it's like really difficult to hold them. So I'm busy trying to hold this baby, and it's slipping out of my hand. It was just so funny. But anyway, eventually we got the baby out, because the baby comes out head sideways, and then it turns, and then it turns again. Anyway, you learn this when you get into midwifery. It's called the mechanism of labor. Anyway, so then eventually the baby does what it needs to do, and it got out with minimal tears to the mom. Like, there really wasn't a significant one. It was like a small one, and with some of them we actually don't even stitch because it can heal nicely by itself. And then the baby comes out, we dry the baby, and I've been hearing a lot of people that, do you guys hit babies? No, we do not hit babies. We just wipe them, and we need to make sure that they're crying. Obviously there are some cases when we need to tap them on the back, like if they come out and they've swallowed some fluid, or they've got some snot in them and is making them have difficulties breathing, then obviously we turn them on their side, and then we just tap them gently so that all that fluid comes out of them, and they can sort of cough it out, and then they can cry properly. Because we've got what is known as an APGAR score, which is different things that we need to check on the baby when they come out. So there's things like, are they moving their hands, are they crying properly, what color is the baby, and that sort of thing. So the rubbing and the tapping on the back obviously helps the baby to stimulate all those reflexes and that sort of thing, so that we know that our baby is well. And then obviously if they're not doing those things, then resuscitation might need to be done, or they might need to be put on oxygen and that sort of thing. So once the baby's out, you wipe them, and then we wait like 2-3 minutes before we clamp, and then we clamp, and then we cut, then we give the mom the baby, or you can give the baby before you even cut, and then they cuddle a little bit, and then you can cut the umbilical cord afterwards. So birth, it's such a beautiful process. Like, I really didn't think I would love midwifery as much as I do, but I've been loving it. Like, I'm obsessed. There's a lot of critical thinking that happens there, because there's a lot of complications that can happen with our mothers. So as a midwifery student, you need to constantly be thinking of, what if this happens, and what am I supposed to be doing to prevent those things, or to detect those things, and that sort of thing. So I have been loving it. It's so much fun, and it's so quick. Like, the thing is, for me, like, I really didn't enjoy clinics that much because it's too slow for me. Yes, there are days where it's quick, there's a lot of patients coming in, but it's not as fast paced as labor is. Labor is almost compared to like how the emergency department works, because things have to happen so quick. You can't just take it slow and take your time. I remember there was this one day we had a potential BBA. So a BBA is a born before arrival. So it's a baby that has either been born at home or in the process of coming to the hospital and that sort of thing. So there's this one day, it was a weekend. That day, like, it was so quiet, things were just going smoothly. Like, we had one birth in the morning, and the rest of the day we're just making sure that the moms that had their babies in the morning, they were feeding properly. We're checking their blood pressures, their sugars, and all of that. Out of nowhere, the operational manager, she comes out of us. She's like, go downstairs, there's a BBA. And as a student, we don't know what is happening. How does this whole protocol work with BBAs? Because, like, okay, what's happening? And she's like, we guys are still standing there. Go down, there's a BBA at the entrance. So we literally just ran. No gloves, no nothing. We just literally running to the entrance. And in my head, I'm like, okay, we are running. We need to get a wheelchair for this person. But also, like, what are we going to do when we see this baby? Because we didn't have gloves. We didn't have a blanket, nothing. We just literally were told to run and go fetch this patient. Anyway, so we are running. We're trying to get a wheelchair. There was no wheelchairs, which was weird. Anyway, eventually found a wheelchair. We get to this car of the patient, and this patient didn't even have the baby was still in, but she was almost fully dilated. So anyway, so obviously we relaxed, but then as we found the wheelchair for this woman to get on, the rest of the labor staff that we had left inside are coming down. One has got a clamp, one has got a scissors, one has got a blanket, and they were literally all ready to catch this baby. It was the most hilarious thing. So literally our whole nursing staff was standing outside ready to catch this baby, and there was no baby. Anyway, so eventually this woman had to get on a wheelchair, and then we got in, and then after, I think, like, most after like 45 minutes to an hour, then obviously she became fully dilated. Like, she was lying on her side, and then out of nowhere we hear like a pa, and then that was the membranes rupturing. Her water broke, and we literally saw it just splurt out of nowhere, and then we knew she was ready. And obviously, for patients that have had births before, they dilate like really quickly, so obviously you need to be ready to catch anytime. So as we were doing her observations, because when the woman comes in, we need to check her blood pressure, we need to check her iron levels, we need to check how far dilated she is, if the membranes have broken, and all of that jazz. So we checked and all of that, and within 45 minutes she was ready to give birth. Like, within 10-15 minutes that baby was out. So it's definitely exciting. I've been loving it. So from now on, I forgot to mention, I was in a high risk hospital. So in our hospital, we deal with somewhat complicated issues. So it's patients that either have diabetes, high blood pressure, or there's some other complications that causes them to deliver in our hospital. So that has been very exciting for me, because there's a lot of things that we're dealing with. But now I'm going to an MOU, which is a maternal obstetric unit, or just a normal clinic for deliveries. So I'm interested to see how that's going to go, and if it's as fast paced as in the hospital setting, because the hospital setting, I've been loving it. Like, I enjoyed it so much. And yeah, anyway, this is just like a little diary entry that I'm making for myself, so that eventually when I give you guys a full update on how midwifery was for me, I would have put all my thoughts together instead of now trying to remember everything. So anyway, that was how high risk nursing was. I'll let you know how low risk will be. So it's officially been a month and a little bit being into the whole midwifery thing, and guys, I'm happy. I think there's that TikTok. Guys,
I did it. I found the person that makes me the happiest I have ever been.
Yeah, that's exactly how I'm feeling with midwifery. Like, I think I found the one for me, but also, I haven't been it for that long, and also haven't seen other specialties. So I really can't say I found the one, but right now I'm in love. So I'm going to enjoy the journey as much as possible. So currently I've been at a low risk MOU, maternity obstetric unit, or a maternity clinic. So this is like, a community clinic for, pregnant women and that sort of thing. So it's a lot more crazy than it was at high risk. So let's start with antenatal, which is while you're still pregnant, you haven't given birth and that sort of thing. So usually like from the morning, like 7 till 1, those were our crazy hours, because we've got patients, they must come in. When they come in, you must check their blood pressure. The reason why we check the blood pressure, obviously we need to know their well-being, but also if you've got high blood pressures, you could be at risk of developing gestational hypertension. You can develop preeclampsia, eclampsia. Those are all conditions that have got to do with your blood pressure, which is very detrimental to your baby. So we need to make sure that those vital signs are being checked properly, and we've actually discovered a few of them that have had like really, really high blood pressures, and they had to be transferred to our local district hospital. So once they come in, if you've got your blood pressures done, then we need to check the urine. When we check in the urine, we need to check if there's any signs of proteins, leukocytes. Protein, it could be an indication of the high blood pressure issue. Those come together. And then we've got leukocytes, that could be a UTI issue. And then sometimes you can have your ketones, which is usually regarding hunger and that sort of thing, but there's more other things that happen with that. And then if it's your new bookings, they'll have their height taken, their weight taken, and then there's obviously bloods. Guys, I took my first bloods. I was so excited, like it's so much fun. Like I think I'm a pro at it now. Like I love taking bloods. It's like so much fun. Anyway, so then they take the bloods. You're taking to check for your syphilis, which is your STI. Then we need to check your blood grouping, because if you've got A positive, there's a whole thing that goes with your incompatibility between the mother's blood and the baby's blood and that sort of thing. So we just need to check that. And then also we check for your HIV status. We check your HB. If you're HIV positive, then we need to check viral load, CD4 count, because that will affect your baby. Then also there's a whole thing that goes with blood. So then after that, then we need to do a history taking. So it's like this it's not a really long page, but it's a lot of questions that you have to ask your mom. You need to ask their mom about their previous history regarding pregnancies. Have they ever had any terminations, miscarriages? How many babies do they have? Are they alive? Are they dead? What were their weight? Was there any complications? What complications were there? And you have to get a whole long history. And then we need to know about the patient's medical history. Do they have any conditions in their family? And then also we need to check their blood pressures. And then we need to check down there, which is your vaginal examination. We need to check if there's any warts. Then also if there's any discharges. We teach the mama by the danger signs. So you've got your maternity case record book. So in that one, it literally teaches you everything. But there's a whole long thing that happens with that. Once we've taken the history, sometimes they'll be scheduled for an ultrasound that same day, or they'll be given another day to come for the ultrasound. But also we measure that tummy, because if your uterus, if it's at certain positions on your tummy, you're a certain number of weeks. So for example, if your we call it the fundus. Let me just use the proper terminology, because if I try to dumb it down, I'm going to confuse you. If the fundus of the uterus, which is the highest part of the uterus, if it's like, for example, by your umbilicus, then you are 22 weeks pregnant. And then there's a tape measure that we use to see how many centimeters you are, and the centimeters correlate to how many weeks you are, and that sort of thing. So that's a whole thing that happens during the day. And then you've got follow-up visits, which is people that have come to the clinic already. So they come in, they also get their vital signs taken. Then most of them are coming for their results for like bloods or for the urine that was taken, and obviously seeing the well-being of the mom. How is she coping with the baby? Is it growing well? Is there any abnormalities and all of that? So that whole thing can take the whole morning, which is usually the whole morning. Like with clinics, literally from morning till like 2-1-ish, that's when you're the most busy. Like we rarely get time to have tea. Like I usually have something to eat before I start work, and then I have lunch like at 2 when we're done. So the antenatal ward side can really be busy. Like we had one day where we had like 70 patients coming in, and then we had a lot of bookings. So new bookings take a lot, because of a lot of investigations that I have to happen. Because it's your very first time that you're giving birth, there's a lot of things that we need to know, because that will determine if you're gonna be a high risk mom, if you're gonna be a low risk mom, and that type of thing. So that whole thing can take a while. But that's antenatal. Antenatal is really chilled. It's so much fun. It's a lot of interaction and conversations with the mom about how they are experiencing the pregnancy. A lot of them have questions about, okay, at this stage, how many weeks is my baby? What things can I feel? Your pre-midwifery or your first time moms or first time being pregnant, they are the most cutest patients ever. Like, I absolutely love pre-midwifery because they are so inquisitive. They want to know what is happening with my pregnancy. Is this normal? Is this not normal? And that sort of thing. And also, like, your teenage moms, they're also like I feel like they've got my heart, because for me, like, I had this one patient. She was 16. Like, she just felt like my little sister, and I wanted to care for her so much. I'm just like, oh child, why are you pregnant now? But it's happened. Now we need to give you as much information as you need to take care of this baby, take care of yourself. There's a lot of health education that goes on in antenatal. So if you're ever going to work in antenatal, you need to make sure that you know information. Obviously, you need to know your information everywhere that you're working, but in antenatal, there's a lot more questions that the moms ask than in the labor ward, because in the labor ward, they're way too focused on the pain and what's happening. They really don't want to be knowing information about the pregnancy, if that makes sense. But yeah, so antenatal is really fun, and it's like really busy in the morning. Then after 2, it's quiet. Usually by like 3 we were going home already. So working antenatal is really fun. I must tell you that I interchange between antenatal and labor. So in 1 week I can be working antenatal, and then the antenatal, which is 7 to 4, and then labor, which is the following week, which should be a 7 to 7. So that's antenatal side. I love it. It's so much fun. But I feel like, giving birth and the whole, doing the whole physical process is where my heart is. I absolutely love delivering babies. So I wouldn't mind working antenatal for the working hours, and obviously for that interaction and conversations with the mom. But I feel like right now I'm into the whole adrenaline thing. So I really want to be hands-on with the delivery. So come labor ward. So with labor ward, every day is a whole different thing. So how our labor ward is set up is we've got 3 delivery rooms with a total of 5 beds. And then we've got also a postnatal side that's attached to it. So the postnatal side, I really haven't worked much on it, because there's a whole different sisters and nursing staff that deal with that. We only deal with postnatal patients, I think, for like the first 2 hours, and they get transferred to the postnatal ward. Then they're being dealt with someone else, or if you're working night shift. But I've only been on night shift for 2 days, so I really haven't had much interaction with postnatal side. But anyway, back to labor. It can be really crazy, or it can be really quiet. Like, we've had days where babies are popping here and there. Like, there's been days where I arrive, like within an hour someone is delivering, and it's very dramatic. It really is, because you've got a lot of moms. There's very hysterical moms, and there's very chilled moms. The hysterical ones are the ones that, in my opinion, give us the most problems. But I mean, I understand you're in a lot of pain. Labor is not to be joked with. But the thing is, when you're hysterical, you putting a lot of pressure on the baby, because most of them, when they're screaming and shouting, they bear down, or the grunting that they do, that it pushes the baby down. And if you're not fully dilated, you're actually causing a lot of compression on the baby, which can decrease the oxygen flow that's going to them, and it can cause them to pull inside. The only reason a baby will pull while they're still inside the tummy is because they call it fetal distress, where you are doing a lot of outside things that causing the baby to be uncomfortable. So as a result, I've had a lot of meconium stained. Meconium stained is when the baby pulls inside, and then it comes out with a pull, and we have to resuscitate them, that sort of thing. So in those cases, it can become really, really, really dramatic. And then also I saw my first breach. It was like, obviously it was scary, because there was a lot happening there, but it was also really exciting. So a breach is when the bum comes out first. It was the craziest delivery I've ever interacted with. Well, second, because I'll tell you about the other one. So the first one, the bum came out first. So when the bum is sticking out, they say you're not supposed to mess around with the breech, because the baby will somewhat help itself the baby will sort itself out, is what I'm trying to say. But the mom was really hysterical and that sort of thing, so we sort of had to help. I wasn't delivering, but I was obviously helping, passing instruments and that sort of thing. So the bum came out first, then they had to do an episiotomy to just make it push forward, and then they took out the leg. So you've got this baby with the head sticking in, and then the legs are out, and then it's some sort of turned out, and then they had to remove the arm, and then they had to deliver the head, which was the craziest delivery, because we're at a low risk clinic. We usually don't deal with such high risk bridges. They're high risk, but this mom came, she was unbooked, and she's unbooked, she's delivering fully dilated. You gotta deal with it. But usually if we had found that out before she delivered, we'd have sent her to our district hospital. But that one was crazy. And then also we had a shoulder dystocia. So a shoulder dystocia is when one of the shoulders are mispositioned in the birth canal, and they make it difficult for them to come out. They do the turning by themselves, and we just help them once the head is crowned and the head is outside. So when there's shoulder dystocia, the normal turnings that the baby needs to do are not happening correctly, and the shoulder gets stuck. So the head can come out, but because the shoulders are mispositioned, it makes it very difficult. And it was a lot of tugging and pulling to get this baby out, and then we had to resize the baby. And then obviously, because the baby was in so much distress, they pooped inside, so we had to suction. Then obviously there are a lot of grunting issues, and the baby had to go to our district hospital and that sort of thing. So I've definitely had a lot of crazy stuff, but overall it's been so much fun. Like labor, I enjoy it. There's a lot of adrenaline rush that's happening. You're trying to catch babies. There's been days where we are finishing with one delivery, another baby is popping out, or a sister is busy somewhere, in this head I've had literally this mom name, she was grunting the whole time and all of that. So all of a sudden she's like, sister, something is burning down there. So obviously I opened the sheet, and the baby's sticking out. I'm just like, what? This baby's out here already. And then you have to get glass, you have to get the trolley, get this baby out. But yeah, it's been so much fun. I enjoy labor. You have no idea the amount of joy that it gives me to just present this baby to the mom, especially for some moms that have been in labor for 2 to 3 days on end. Your primigravidas, it takes them a long time. What's your first time being pregnant? It's your first time your body is experiencing such sensations, such feelings, such processes, that obviously it takes a while to progress and that sort of thing. So they'll be so tired, they'll be so exhausted, they'll be so over it. But once you give them that baby, the love, it's just amazing. We literally, there was this one mom, after the baby came out, she was literally talking to the baby, and she was being all cute and all that, and the sister was joking with her, oh my gosh, this baby's gonna be so spoiled, because it's just an amazing feeling to hold that baby. Trust me, when I held the baby that I delivered, I felt a whole rush of emotions. So now imagine a woman was just pushed this big human outside, and they're finally in your arms. You can hear them crying, you can feel them sucking on your breast. Guys, it's such an amazing feeling, and I wouldn't trade it for the world. I absolutely love what I'm doing. And yeah, so far it's been so much fun. The nursing staff that I'm working with are amazing. There's been some that have tried to rub me up the wrong way, but we keep it pushing and we keep it moving. But overall, I've been enjoying midwifery. So comment down below what questions or what things do you guys want to know about midwifery, because this is me just telling you how I've been feeling. I'm not sure what questions you guys have, so comment down below, and then maybe I can do a Q&A session on that, so I can answer all your midwifery questions, because I know a lot of my audience wants to do midwifery, so I'm interested to see what type of questions you guys have. So this is the end of my rant and this whole story time of how midwifery has been. Don't forget to comment, like, and subscribe. Until next week Friday, 12 p.m. South African time. Have an awesome day. Bye guys.